So, appropriate initial management of pneumonia relies on the accurate assessment of severity of disease. To support clinical assessment, several severity scoring systems have been developed. These tools facilitate the prompt identification of patients with severe disease who require ICU level care. Equally, they help us identify those patients that can be safely treated at home. Studies have demonstrated that care provided based on assessment of disease severity using such severity scoring indexes are associated with improved patient outcomes. So the CURB 65 is one such disease severity scoring system that has been validated for predicting mortality in community-acquired pneumonia. And specifically, it has been validated in some low and middle income countries, most notably in India. The scoring system is an acronym for each of the risk factors associated with increased mortality from pneumonia. Each risk factor scores 1 point for a maximum of 5 points. So the components of the CURB 65 are C for confusion, that is new onset, U for urea nitrogen, greater than 7 millimoles. R is for respiratory rate greater than 30. B is for blood pressure less than 90 systolic or less than 60 diastolic. And 65 is for age greater than 65. So the risk of death at 30 days associated with the CURB 65 score is if a score is less than 2, the mortality rate goes anywhere from 0.6 to 6.8%. A score of 3 is associated with a 14% mortality rate, and a score of 5 is associated with 28% mortality rate at 30 days. So we use the CURB 65 to decide who needs to go to the ICU, who can be treated as an inpatient but on a regular ward, and who can be safely treated with oral antibiotics at home. And typically, we say that patients who have a score of 0, 1, or 2 most likely can be treated at home safely with oral antibiotics and close follow-ups. Patients with a score of 3 should be hospitalized, but typically can go to a normal inpatient medicine ward, and patients with a score of 4 or 5 most likely require the intensive care unit.